Hey everyone, and welcome. As clinicians, we eventually move past just knowing the names of drugs. We have to learn to speak the language of how a drug actually behaves inside the human body. And that language? That's pharmacokinetics. The data we pull from a patient's plasma sample isn't just a bunch of numbers. No, it's a whole story. And today, we're going to learn how to read it.
I mean, this is really the whole ballgame, isn't it? Everything we're about to talk about is all geared towards answering this one question. Because the skill to look at raw data and turn it into a concrete clinical action, well, that's what separates a good clinician from a truly great one. So let's start with the first chapter of our story. Every single time we draw a blood sample and measure a drug's concentration, we're really just capturing one snapshot in time of that drug's journey. But when we connect those snapshots, that's when we can map out the entire story, from its absorption and distribution, all the way to its metabolism and finally its exit from the body.
Now, to understand the story, we need some vocabulary. And these 5 parameters, they're the absolute core of pharmacokinetics. Think of it like this. Bioavailability tells us how much of the drug actually gets into the system, volume of distribution tells us where it goes once it's in there, and the elimination rate and half-life tell us how fast it leaves. So what about the area under the curve? Well, that measures the total impact the drug has over time. For this explainer, we're going to really deconstruct 2 of the most important pillars here, bioavailability and AUC. Okay, first up is bioavailability, which you'll almost always see represented by the letter F. This is really our starting point. It tells us how much of the drug we give a patient actually gets a chance to do its job.
So, to put it simply, if a patient takes a 100 milligram pill, but only 70 of those milligrams make it into their bloodstream, ready to work, the bioavailability, or F, is 0.7. Pretty straightforward, right? But the real question is, what happened to the other 30 milligrams? For just about any drug you take by mouth, its biggest obstacle is the liver. See, after the drug gets absorbed from the gut, it travels straight to the liver, which kind of acts like a bouncer at a club. It metabolizes and inactivates a chunk of that drug right then and there, before it ever gets a chance to circulate to the rest of the body. And we call that the first pass effect.
And this is exactly why the route of administration is so critical. An intravenous or IV injection puts the drug directly into the bloodstream. It completely sidesteps the gut and the liver's first pass metabolism. That's why we say IV administration has an absolute bioavailability of 1.0 or 100%. And it's why we use it as our gold standard for comparison. All right, let's build on that and move to our next key term. If bioavailability tells us how much drug gets in, then the area under the curve, or AUC, tells us the total exposure the body has to that drug over a period of time.
I want you to picture that classic concentration time curve as the complete story of the drug's presence in the body. To capture the entire story from beginning to end, we measure the total area under that curve, the AUC. And mathematically, we calculate this from the moment the drug enters all the way out to, theoretically, infinity, until that very last molecule is gone.
Now, I know calculating to infinity might sound a little weird, but we do it because a drug's concentration is always halving. It gets closer and closer to zero, but it never technically hits it. So this calculation ensures we capture the absolute complete picture of a patient's total drug exposure.
So let's get to the crucial point. Why do we care so much about this number? Well, for one, AUC is the gold standard we use to prove that a generic drug is truly equivalent to its brand name original. Beyond that, it's directly linked to both a drug's effectiveness and its potential for toxicity, which makes it absolutely vital for safe and effective dosing. Okay, so we know what AUC is and why it's so important. But how do we actually calculate it from a patient's real-world plasma data? We've got 2 main methods. The first is the trapezoidal rule, which you can think of as the universal all-purpose tool that works for just about any situation. The second is the residual method, which is more of an elegant shortcut, but it only works under specific conditions. The trapezoidal rule is really as straightforward as it sounds. It works for any drug because it just breaks that big, complex curve down into a series of small, easy-to-measure trapezoids between each data point we have. Then we just add up the area of all those little shapes to get our total. And the area of each little trapezoid is calculated with this simple formula. We just repeat this for every segment between our data points and add them all together. It's a reliable, rock-solid, universal method for finding the AUC. Now,
What about that shortcut? Well, for certain drugs, specifically ones that follow what we call a one-compartment model after an IV dose, their concentration declines in a really predictable exponential way. And what that means is, if we plot the logarithm of the concentration instead of the concentration itself, that curve magically becomes a straight line.
And this is the magic of the shortcut. By turning that curve into a straight line on a semilog plot, we can suddenly describe the drug's entire journey with just two key parameters that we pulled directly from that line. The slope of that new straight line, that directly gives us the elimination rate constant, or K, which tells us exactly how quickly the body is clearing the drug. And here is the big payoff. Once we have the key parameters from that straight line, we can calculate the total AUC with this incredibly simple formula. No more adding up a bunch of little pieces, just one clean calculation. It's a beautiful, elegant shortcut for the right type of drug.
Now, I've used the term one-compartment model a couple of times, so let's take a quick second to clarify what these models are and why they actually matter for our calculations. The one-compartment model is the simplest way to look at things. It basically assumes the drug distributes instantly and evenly all throughout the body, which results in a simple, straight-line decline on our semilog plot. A lot of drugs, like aminoglycosides, fit this model pretty well. But other drugs, like vancomycin, are better described by a two-compartment model. This model recognizes that the drug first fills up a central compartment, the blood and organs with great blood flow, before it slowly distributes to a peripheral one, like fat and muscle. And that creates a more complex two-phase decline curve. So we've deconstructed bioavailability, AUC, the different calculation methods, and the models. Now let's bring it all back home. Why do we go through all this trouble? What is the actual payoff in our day-to-day clinical practice?
This is why it all matters. We deconstruct this data to make sure the generic medications we dispense are just as safe and effective as the brand names. We do it to fine-tune a dose for one specific patient, getting them the maximum benefit while minimizing the risk of side effects. And ultimately, we do all this to move away from one-size-fits-all medicine and get closer to truly individualized patient care. Every single set of plasma data contains a unique story about a patient and how they're responding to their medication. By really understanding these core pharmacokinetic principles, you gain the ability to read that story, to interpret what it means, and to use it to make the best possible decisions for them. You now have the tools to read the story in the data.